John Jefferies, and it's my pleasure to bring to you the ACC 2021 late-breaking clinical trials perspectives from heart failure, imaging, and ACS. I'm pleased to have with me Dr. Smadar Kort and Dr. Michael Kontos today, who will be discussing multiple trials. The ACC.org Heart Failure, Non-Invasive Imaging, and Acute Coronary Syndromes editorial teams have developed additional education from the ACC 21 late-breaking clinical science. This education focuses on high-impact recommendations that can be potential areas of confusion or controversy, or simply new evidence that represents a significant change from former standard of care. And today we'll focus on the ADAPTABLE, the LAOS III, FLOWER-MI, EXPLORER-HCM, Galactic HF trials. So with that, I'll get us started with speaking about ADAPTABLE. The ADAPTABLE trial randomized participants with established atherosclerotic cardiovascular disease enriched for a number of factors, which may include an LV ejection fraction less than 50% or chronic heart failure, to either aspirin 81 milligrams per day or 325 milligrams daily. While the study did not directly address aspirin use in heart failure, 22.8% of those in the 81 milligram and 23.8% in the 325 milligram group had prevalent heart failure. The study found no significant differences in cardiovascular events or major bleeding between the two groups. Aspirin discontinuation was 7% in the 81 milligram and 11.1% in the 325 milligram group. Additionally, 41.6% of patients assigned to 325 milligrams crossed over to 81 milligrams during the study. Data are inconclusive regarding aspirin use for primary prevention and heart failure. Both the ACC and HA, as well as the ESC guidance documents, state that there is insufficient evidence to recommend aspirin for heart failure in the absence of other indications. For heart failure patients without a separate indication, the ADAPTABLE trial does not provide guidance since inclusion criteria required coronary disease or atherosclerotic disease. However, for heart failure patients with a specific indication, the ADAPTABLE trial suggests that aspirin at 81 milligrams may be preferred due to higher adherence and equivalent efficacy to aspirin 325 milligrams. A separate major take-home point was the study design itself that provides an attractive framework for future studies, including heart failure cohorts. This was the first clinical trial to use the pCoreNet electronic data infrastructure, which allowed identification of participants via electronic health records who were e-consented, directly randomized to open label aspirin use with no in-person visits during the follow-up. Potential benefits include more pragmatic identification of participants, lower study costs, obtaining real-world data, and may permit more inclusive enrollment of diverse populations. However, the trade-offs include the open label nature of the study and potential for misclassification or underreporting outcomes. So with that, Mike, would you have any other additional comments on this study?
Yeah, thanks. I found this an interesting trial. It's always struck me as interesting that we've had aspirin for well over 100 years, and we're still trying to determine what the appropriate dose is. This is reflected, as you noted, in the guidelines, where the Europeans at least have come out and specified 81 milligrams, and the U.S. guidelines say 81 to 162 based on, I think, the ICIS 2 trial. So this does help inform us what better dose we should use. And I think it does at least tell us, although the design of the trial didn't allow us to make definitive determination of the appropriate dose, I think that the patients are telling us what dose is. The fact that more than 40% crossed over from the high dose to the low dose does indicate that the lower dose for most patients is going to be preferred. I think this is also indicated by what clinicians are preferring. Well, I think when the trial was designed, over 50% of people were taking the higher dose. Now it's closer to 80% when they started or at the 81 milligram dose. The trial design, also, I agree with you. It's a great way to be able to perhaps to get more people enrolled in trials. I think one important caveat is that what did allow this to enroll so easily, I think in part was related that they were talking about a drug, aspirin, that's been around for a long time, that everyone is already taking, the majority of people are taking anyway. So I think that decreased the amount of time and complexity for enrolling people in the clinical trial.
Agreed. Thank you. So, lots to potentially look forward to with new trial designs and perhaps more inclusive and broad based. So, thank you for that great discussion. Next, we'll visit the LAOS3 study, which was left atrial appendage occlusion during cardiac surgery to prevent stroke, the impact for patients with heart failure. And this trial was recently published as a randomized controlled trial, which tested whether surgical left atrial appendage occlusion compared with no occlusion among patients with atrial fibrillation undergoing open heart surgery was beneficial. The investigators from over 100 centers tested to see whether this procedure, which is commonly performed at the time of cardiac surgery, can lower the long term risk of the primary outcome of ischemic stroke or systemic embolism. They found that the performance of occlusion at the time of surgery reduced the long term, which is 3.8 years, risk for the primary outcome. Turned out data 4.8 versus 7% with a significant p value. Importantly, if patients enrolled in the study, over 50% had a history of heart failure, and the majority of the surgeries were either valve interventions, coronary artery bypass grafting, or atrial fibrillation ablation. So patients with heart failure commonly are referred for cardiac surgery, including revascularization, atrial fibrillation ablation, or valvular intervention. Atrial fibrillation is a very common comorbidity seen in patients with heart failure, which does increase the long-term risk of stroke. While the study did not investigate whether anticoagulation can be withheld in these patients, it did demonstrate the efficacy of left atrial appendage occlusion to reduce the risk of stroke. For those taking care of patients with heart failure, one should consider occlusion superior to no occlusion to reduce the long-term risk of ischemic stroke or systemic embolism in patients with atrial fibrillation who are being considered for open heart surgery. So with that, Smadar, do you have any comments on this interesting study?
Yes, thank you. So I'm thinking about this trial as an imager, and as someone who does interrupt, he is, and I think that one of the main teaching points of this trial is that I expect the guidelines to recommend surgical occlusion of the left atrial appendage now in growing number of patients. As this trial suggests, those who have atrial fibrillation and high CHA2DS2-VASc score, and that to translate to more patients who will have occlusion of their appendage, and that would behoove the imager during the time of surgery to really look carefully at the left atrial appendage, assess it before it is occluded, and even more importantly, post-PAB after it has been occluded to make sure that the occlusion was adequate. And likewise, patients who are physicians who are performing transesophageal echoes who will see those patients at one point after surgery will need to know how to carefully analyze the occluded appendage, make sure that the repair was done adequately, that there is no residual flow, and that there is no clot attached to the surface of the appendage. So I think that as imagers, we will see more of those patients, and we will need to be very careful about how we actually image them and take that into consideration.
I would agree. I think this is a guideline changing trial. We're going to see this used much more consistently in the future. It would be interesting to have a little more detail about some of the subgroups. For example, about half the patients had persistent or permanent AFib, and only half had paroxysmal. Is there a difference in outcomes in that cohort, or those patients who were not taking any coagulation? Because I think that's obviously going to be one of the questions that come up. Patients on anticoagulation, now they have a contraindication has arisen. Can we comfortably say that they're safe to come off, or do we have to do, as you said, actually do another imaging study to make sure that appendage is truly occluded?
Agree. Great discussion. So next, perhaps we can visit Galactic HF. Smadar, would you like to tell us a bit about the trial?
Sure. So, in the Galactic heart failure trial, the effect of cardiac myosin activator, namely omecamtiv mecarbil, was tested versus placebo in the effect on the primary composite endpoint of time to first heart failure event or cardiovascular death in patients with heart failure and severely reduced ejection fraction, EF of 35% or less. And the outcome of that study actually showed that the risk of those endpoints was almost 1.8-fold greater in those who have the lowest ejection fraction, and those were patients who had EF of at least 22%. That compared to those who have EF of 33% or greater. And to me, again, as an imager, I think this is very, very critical. So when we assess ejection fraction or when we assess systolic function, we are encouraged to calculate the ejection fraction and be as accurate as possible. The American Society of Echo recommends performing 3D echo and using those volumetric algorithms to calculate the ejection fraction. And if 3D cannot be performed, then biplane Simpson for really quantitative assessment of the systolic function. So I think that this trial really emphasizes how important it is to quantitate ejection fraction in order to be able to, in this case, predict outcome of this type of therapy. And I think that that would also make us really think more carefully about using even more accurate ways of assessing systolic functions, such as strain imaging, global longitudinal strain, etc. I think that it really it is extremely important to be as quantitative and as accurate as possible, and not just grade systolic function as mild, moderate, or severe.
Yeah, I agree. From a heart failure perspective, obviously, this is a drug that's working at the level of the sarcomere by cardiac myosin activation. And I think it's important. Some of the findings is that we found that the LV ejection fraction was actually the strongest modifier of treatment effect, and that patients in the lowest quartile of ejection fraction, less than 22%, treated with omecamtiv versus the placebo, had a greater reduction in first heart failure event or cardiovascular death with significant hazard ratios than patients with the highest quartile of ejection fraction, meaning those over 33%. I think this study demonstrates the clinical benefit of omecamtiv in heart failure patients with the lowest ejection fraction, which is a population that we know is at the highest risk for adverse events. We do think that this is a congruent with the mechanism of action proposed for omecamtiv. I think this is a particularly notable finding, as previous studies have failed to show benefit of augmentation of systolic function with oral inotropes in patients with systolic heart failure. So I think this really stresses the importance and relatively novel nature of omecamtiv's mechanism of action and its potential role in the clinical management of patients, especially those with the most severely reduced ejection fraction. So, thank you for that great discussion about Galactic. I'm going to mention briefly EXPLORER-HCM, which we think was an important study in the cardiomyopathy space. So until recently, there's really been no specific therapies for patients with obstructive HCM, even though, and in those settings, many therapies are poorly tolerated. So mavacamten is really the first in class cardiac myosin inhibitor, which was studied in this particular trial. And we were looking at an increase in peak VO2 with stable or improved New York Heart Association functional class as endpoints in adults with symptomatic obstructive HCM. And as we know, many of the therapies we try and use to mitigate obstruction oftentimes may be difficult to tolerate. But we know in the secondary analysis of of this study, Professor Spertus and his colleagues actually assessed the impact of mavacamten on patients' disease-specific health status as measured by a change in their Kansas City Cardiomyopathy Questionnaire at 30 weeks from baseline. The changes were greater with mavacamten than placebo. Importantly, similar benefits were also seen across all of the subscales, which we think is very important. And a very large improvement, meaning greater or equal to 20 points, was much more common in the mavacamten group at 36% than the placebo group, which 15%, with an estimated absolute difference of 21%. This suggests mavacamten is very well tolerated and is associated with improved symptoms, physical and social function, and quality of life, with a low number needed to treat of 5. So this makes mavacamten a very important drug and the first disease-specific pharmacologic option for obstructive HCM. However, it still remains to be seen if these benefits will be seen in a broader HCM population, including those that maybe have a reduced ejection fraction, those with a history of syncope, or those with a recent history of sustained ventricular tachycardia. But I still am very strongly impressed with the results of these studies simply because it is a targeted therapy that really does make sense at a physiologic level or at the sarcomeric level in patients with obstructive HCM. So lastly, we'll speak about Flower MI. And Mike, if you would you mind telling us about the trial and your thoughts?
Yeah, I'd be glad to. So in patients with STEMI who present with multivessel disease, we have pretty good data now that complete revascularization reduces events. One of the questions, though, is exactly how do we determine whether those other arteries are significant or not? Do we use a physiologic approach using, say, a device such as FFR, or just do a visual assessment, or as Eric Topol might have said, an oculostenotic reflex of just dilating the arteries that look significant? The Flower trial was designed to really try to look at that. They randomized almost 1,200 patients to one of the two strategies, FFR or ocular, or a visual determination of overall significance. In that study, as you might expect, using FFR to determine significance significantly reduced the number of patients who under revascularization in the other arteries from 91% in the visual determination down to 50%, 56% in the other cohort. As you might expect, there was about a significant reduction number of stents used as well. However, as to different than what the investigators might have thought, there tended to be a worrisome trend towards increased adverse events, although they weren't significant, with a higher rates of reinfarction, but no difference in mortality. The trial really wasn't powered enough to look at all the events, and the confidence intervals were relatively wide, but still I think gives some concern that the FFR guided approach resulted in worse outcomes. Another interesting aspect of this trial was what if we're talking about doing complete revascularization, do we do it in the same setting or as a staged procedure at a later time? At least the limited data that's out there would appear that there doesn't appear to be a significant difference, although many of them used a delayed strategy. This trial, the Flower trial, was not designed to look at that, but left it up to the investigator. And it did turn out that we do have at least a preference from the investigator point of view, in which 95% of the patients had a staged procedure in which it was done either at a later setting or during a different admission. So I think it does provide some interesting information. And there are, I think, at least 2 or 3 other trials that are examining a similar approach that hopefully will provide us more information on the optimal way to determine whether a lesion is significant or not.
Thank you. Thanks, Mike. Well, I want to thank everyone for these wonderful summaries. Thanks to my co-panelists. I hope everyone has taken away some useful information that may help in your daily practice, and we look forward to further broadcasts in the future.
Thank you.
Thank you.